everyone, this is Courtney Farrell. As I stated in my introduction, not sure if y'all had a chance to watch it or not, but I am an ER nurse. That's where the majority of my time has been spent as a nurse. I've been a nurse for about 3.5 years and worked in my current job for almost 3. So that is where the big bulk of my experience comes from. I work in a very, very, very busy, especially lately, emergency department here in Raleigh. And we see a lot of patients who come in complaining of symptoms due to changes that were made in the dosages of their daily medications that were prescribed by their primary care doctor. One example of this, I had an older patient come in by EMS whose chief complaint was a syncopal episode. EMS reported that the patient was very hypotensive, positive orthostatics, and as I begin to triage the patient, a family member comes back and kind of adds some to the story and says that they recently went to go see their primary care doctor and that there had been a change made into the patient's hypertension medication as they were having some trouble keeping the patient's blood pressure under control, so the dosage was increased. Family also kind of stated that the patient just hadn't been feeling well over the last couple days, had been complaining of some lightheadedness and some dizziness. And so after spending a very large amount of time in the ER with full cardiac workup, patient was eventually admitted for blood pressure treatment or management and further testing. This scenario actually happens a whole lot more often than you would think with blood pressure medications, with insulin, with the diabetic medications. Tweaks to dosages here and there can cause extremes either with their blood pressure or their glucose being too high or being too low that can cause crises, which is when we see the patients majority of the time. With this particular example and this particular patient scenario, could have also had a lot of other potentially harmful effects, such as when a patient had their LOC, if they could have potentially fallen, struck an extremity, broken an arm, broken a leg, also could have hit their head, which can cause a lot of other complications, especially if the patient is on any kind of anticoagulant medication like warfarin or Plavix. I have actually seen that as well. Patients who had some kind of LOC, loss of consciousness, fell, hit their head, and end up with a head bleed because they also are on a blood thinner. Pharmacodynamics is defined in our text as how a drug changes the body. Alterations in drug dosages are an example of the pharmacodynamic principle, specifically related to the dose-response relationship and therapeutic range. The goal in prescribing any kind of medication is to keep patients within that therapeutic range. Our textbook kind of describes this in 3 different phases. Phase 1, where the dosage doesn't really has very little or no effect whatsoever. Phase 2 is where the desired effect of the medication is achieved. And phase 3, our book describes it as the therapeutic response stops, and it states that adverse effects can begin. In relation to my patient example, it actually went a little bit too far. I don't think this is an example of any kind of toxicity or anything. I think it was just an example of the patient got a little bit too much of their blood pressure medication dosage and went beyond the therapeutic range. In the area that I work, patients are typically seen for acute conditions and are treated and then instructed to follow up with either their primary care doctor or admitted to the hospital. So in my work setting with this principle, it does relate to patient care, but however, probably not so much. We don't get to see it as much, probably as other nurse settings, such as like a primary care doctor's office, where you see patients continually over several years and get to follow kind of their progress. We see patients for a very short period of time, treat them, stabilize them, and either discharge or transfer them to a hospital unit for further care, where we don't really get to see what happens or see how kind of things evolve and unfold. Also, due to the fast-paced environment of the area that I work in, pharmacogenetics is not really something that I've ever seen or used. However, I can definitely see the benefits that can come of it. Using pharmacogenetics, doctors could be better able to assess each individual patient's specific blood type and their specific makeup, I guess, and tailor a specific medication prescription plan to their specific needs. Pharmacogenetic testing could have prevented the ED visit for my example patient, syncope patient and his subsequent hospital stay, because it would have allowed his primary care doctor to make a informed decision as to adjustments in his blood pressure medicine rather than just kind of guessing at it. And it could also be a way to, could also be a cost-effective way to reduce ED and hospital visits due to medication changes, which, like I said before, we see a fair amount of those. It may cost more upfront. However, the savings that you can achieve by either decreasing or eliminating hospital stays and ED visits could definitely make up for it in the long run.